Hi, my name is Darren Brenner, and I'm a professor of medicine and director of the Neurogastromotility program at Northwestern University in Chicago, Illinois. I'm joined today with my colleagues and friends, Dr. Joel Heidelbaugh, who's professor of family medicine and urology at the University of Michigan in Ann Arbor, and Dr. Amal Sharma, who's an associate professor of medicine in the Department of Gastroenterology at Augusta University in Georgia. Gentlemen, welcome and thanks for joining me. And welcome to all of you to this program titled What's Buzzing in IBS-C? Latest Clinical Updates. Today, we're going to focus on some of the most common facts and fiction related to the management of patients with IBS-C. And we have a lot to go through in the next 30 minutes, so I'm going to jump right in and ask, Joel, fact or fiction? The symptom burden and adverse effect on quality of life in patients with IBS-C is substantial. What do you think?
So that's actually a fact, and I think that's something that is really important to understand both in primary care and gastroenterology practices. Certainly the symptom burden is substantial, and most patients will report that their symptoms of IBS will interfere with activities of daily living, and that means social and even leisure activities, things at home, private leisure activities, as well as close relationships, unfortunately. And so there's often also a significantly higher loss of work productivity and presenteeism. A lot of patients will work while sick when they have IBS-C compared to those without. So patients with IBS also experience higher levels of anxiety and depression, with up to 38% report having contemplated suicide, unfortunately, as a result of their severe symptoms. And patients with IBS would often make trade-offs for symptom relief, where a quarter would even give up cell phone usage for a month, and over half would give up alcohol or caffeine for a month if they could have symptom relief.
Yeah, I think it's really interesting. You know, we always hear that the idea of irritable bowel syndrome is, pardon the pun, we're talking about IBS-C poo-pooed, but this really is a significant burden on these individuals. I think we both know an older study from Doug Drossman's lab where he asked people with IBS if they'd be willing to give up part of their life for a cure. People on average said they give up a quarter of their life, which amounted to 15 years for a cure for this disorder. So I think we all agree this is not a nuisance issue. This is a major burden in people's quality of life. Okay, well, what about this? What do you think about stress? I hear all the time, is stress causing my symptoms? Is stress the trigger for my IBS-C? What do you think about that?
So I would definitely say that that's fiction. And we know the pathophysiology of IBS-C is certainly multifactorial. And there are a lot of different components. I'm going to go through this slide very quickly here in a minute. Interestingly enough, my group just had a paper published this week in Neurogastromotility and Motility that showed that between US and European PCPs, about 70 to 75% felt that stress was actually a cause of IBS. And in both groups, US and European PCPs, 98% reported that stress can worsen IBS. So we know in early life there are genetic factors, there can be cultural factors, and certainly environmental factors. And that includes trauma, infection, or even parental behaviors. Lots of stress in our lives. We understand all of that. But I want to stress one thing. I hear, and I know you both hear, patients will come to me and say, my doctor said this is all in my head. And my doctor said that because of my stress, that's what's caused the IBS. So we understand that this can be one element of a psychosocial factor, and that interplays with psychological state, coping mechanisms, and support. But it's important to also highlight that relationship between the brain central nervous system and the gut enteric nervous system. So this is going to impact motility, visceral sensation, immune dysfunction, and certainly inflammation, but also elements of altered microflora and elements of food and diet that I know we're going to get into soon. This can interplay with the disordered gut-brain axis, and this is what creates the symptoms and the severity and the behaviors. What does this mean in terms of outcome? This is what brings to healthcare utilization, certainly the impact on daily function, the impact on quality of life, and then often exorbitant healthcare costs.
So if I'm hearing it's really not one size fits all, it's different strokes for different folks type of disorder. And yes, I think we all agree that stress or stressful situations can exacerbate the situation, but is not the underlying cause for the vast majority of individuals. And I think it's really important, to have this discussion. I think we talk about stress with our patients, and maybe this is part of the reason that stress is part of the myth and misconception, because it's something that we can actually key in on and treat well and reduce the burden of illness that is irritable bowel syndrome, which I think we'll talk about a little bit later as well. Okay, well, I think this is a really important question. And this is something I think that all of us have struggled with since the beginning of time, since we all started practice. And that is, I think we still hear today from the vast majority of our colleagues, whether they're primary care or they're GI based, that irritable is a diagnosis of exclusion. How do you feel about that? What are your thoughts on when you hear that comment?
Sure. And we were just talking about this off camera before we started. And, in our paper that just got published this week, again, we surveyed US and European PCPs. 80% of both groups felt that it was still a diagnosis of exclusion. It remains a challenge. And so if you go back to the work that the Rome group did and look at the Rome 4 diagnostic criteria, even while a lot of practitioners in primary care and gastroenterology are aware or may be aware of these diagnostic criteria, many still don't use them, and many still feel that it is a diagnosis of exclusion. So it's important to highlight these diagnostic criteria. This is a slide, and I pull this up in my practice when I see patients so that we can go over it together. It highlights recurrent abdominal pain occurring on average 1 day a week in the past 3 months, associated with 2 or more of the following. And this is important: pain related to defecation, and or associated with a change in stool form, and or associated with a change in stool frequency. And so I will spend time, I know you both spend time with our patients, highlighting stool form changes and stool frequency changes. These criteria need to be fulfilled for at least the past 3 months, with a symptom onset of 6 or more months greater prior to making that diagnosis.
So how do we break this stereotype or the stigma related to this being a diagnosis of exclusion? I mean, at every lecture, I show the same slide, which is I can ask 8 binary questions based on prospective data. There's an accuracy of almost 98%. I show studies from Europe that say if I run every test versus just a few pointed tests, the outcomes from symptom standpoint are the same. The quality of life outcomes are the same. The only difference is the cost differential, which is in the range of billions in the United States in wasted studies and expenditures. And yet, no matter what I do and no matter how hard I try to argue this, I can't break the cycle. The ACG says it. The AGA says it. And both of those guidelines, they are very clear. Positive diagnostic strategy, minimal diagnostic testing. So do any of you have a theory? What else can we do? Because it seems like we're failing. We're trying to push this agenda. It's the right agenda. It's the appropriate agenda. It's right for patients, but we can't get this message across. So what do we do?
I think it comes down to one patient at a time. I think it comes down to one practitioner at a time. Patients with IBS or patients with IBS-like symptoms can be very complex. And I will tell you my perspective, and I've told you both this before. In primary care, patients come to see me with many issues. If it's going in the direction of anything that may be IBS, I tell the patient, this is going to be one visit for all of this. And then when I'm teaching this, I highlight that fact. I highlight that fact because it allows the practitioner to be able to say, yes, this is complex, but now if I'm aware of these diagnostic criteria, I can give the patient adequate time in a visit and adequately approach this.
I think that's great. You and I practice in the same area. And if I'm being truth in advertising, I trained at Michigan and with you. So I think we have some of the same thought processes on this. But, Amal, you've been down in Augusta for a long time now, and you probably see a bit of a different patient population. What are things like down there? Do people buy in? Do the practitioners buy in down there as well? Or are you still fighting the good fight?
Well, I think I echo what Joel says, but I would just add that when you make the diagnosis, the patients need frequent follow-up, right? Because, no matter what you do, we've shown that there's a high placebo response, and it doesn't matter which provider sees them. So if all the providers and the care team are on the same page that this is a diagnosis and a condition, and we listen to the patient and their problems and manage their predominant symptoms appropriately, then we can drive that point home and not need to do unnecessary testing. So it's hard to do that in one visit. And, we're also strained with our time and our appointments, but if we're able to, see them multiple times, maybe a little bit more frequently at the beginning and then spaced out, I think we can be more successful.
And I think, yeah, for the people who are watching this video live or later on, I think it's important to really stress the fact that when we talk about minimal diagnostic testing, we really mean it. If we look at the guidelines, the recommendations for people with irritable bowel syndrome with constipation is no diagnostic testing. Go directly to treatment. And if they fail therapy, then consider the overlap of pelvic floor dysfunction. On the IBS-D side, we recommend testing for celiac, which is simply a tissue transglutaminase IgA and a serum IgA level to make sure the patient isn't IgA deficient. And then some sort of inflammatory biomarker, either a serum CRP or a fecal calprotectin, which for all practical purposes rules out the likelihood of having inflammatory bowel disease, because you're going to ask about the alarm signs or symptoms, right? We ask about bleeding, we ask about weight loss, we talk about acute changes, we talk about family history. Those things are captured. So I think the take-home message I want to leave people with is everybody that walks in the door does not need a colonoscopy to define irritable bowel syndrome. As a matter of fact, very few do, and that should be based on the alarm signs or symptoms. Are there any particular patients that you feel strongly need these colonoscopies before you're confident making the diagnosis?
Without alarm signs or symptoms, I'm going to say no. About the only time I think I've done this is if patients, and this gets into the IBS-D world more than the IBS-C world, is if somebody's got an unexplained diarrhea and I've ruled out other causes. But for IBS-C, I got to say it's pretty rare.
Fair. Okay. Well, I'm going to shift gears and ask you a few questions now about different therapeutics. And obviously these, thankfully, in 2024 run a spectrum, right? I think when we all first started practicing, there was little to nothing out there. You tried to treat the predominant symptom. Now we can treat the global nature, the totality of IBS symptoms, including pain, discomfort, bloating, distension, and constipation, frequency, texture, straining, sensations of incomplete evacuation. So knowing that we have all kinds of newer therapeutics, whether they're pharmaceutical or otherwise, I guess my first question to you is this. Do you think that over-the-counter agents are effective at relieving the cardinal symptoms of IBS, i.e. all of the abdominal and bowel symptoms?
Yeah, so I think this is going to be a fiction. We're thinking that, we should start with the most mild medicine before we advance our therapy. But, we've looked at studies and the guidelines have made this explicitly clear that the over-the-counter agents, they're really good for the bowel symptoms, but the cardinal symptoms, which you mentioned, which are pain, discomfort, and bloating, they don't really touch that very well, with the exception of soluble fiber. So if we're going to start with somebody who has mild bowel symptoms, but maybe more moderate abdominal pain or bloating or discomfort symptoms, then using soluble fiber, either as psyllium or prunes or kiwi fruit, I think is a good strategy. And maybe even we don't kind of use these in isolation. We sometimes combine therapies. So, it would be a good strategy if somebody had that to start with soluble fiber. When we start thinking about the therapeutic classes, which we're blessed to now have more and more as the years go on, we think of two main classes, the secretagogues that include plecanatide, linaclotide, and lubiprostone, and the retainagogues, which is a newer class of medicines, which includes tenapanor. And these are the kinds of medicines that help treat the abdominal pain, discomfort, and bloating. And I like how our field is moving towards getting more bang for its buck and asking more from our medication classes to not only just treat bowel symptoms, but treat these symptoms as well. So include abdominal pain, include bloating in your endpoint so that we can actually get a more comprehensive relief and global relief for our IBS patients.
Yeah, I think it's a really important point. Studies have shown that the average individual will take 3+ over-the-counter laxatives before they go to see a practitioner. And the vast majority of the data also supports the fact that they're not coming to us because of their bowel symptoms. I've always said, in a person that doesn't have evidence of pelvic floor dysfunction, if I give enough laxative, I'll make you go. It may not be the response you want. It may be diarrhea and extensive diarrhea, but I can make your bowels move. But the patients are really coming to see us because they're not getting the response they need to those abdominal symptoms, what I like to call the visceral sensory symptoms like pain, discomfort, and distension. So I think the message to patients, if they watch this, is this. If you're not getting what you need out of the over-the-counters, it's likely because they can't do it. Come talk to your primary care practitioner or see a gastroenterologist. We now have very good, safe, evidence-based therapies that we can use to treat these people. So that then brings up the question, if we're looking at these FDA-approved therapeutics and we think they have a little bit more bang for their buck, is it fact or fiction that secretagogues and retaining are similarly effective at reducing these abdominal symptoms in individuals with irritable bowel syndrome or constipation?
So that is a fact. We have very large randomized controlled trials that have proven time and time again, and even their meta-analyses, that these agents, these newer secretagogues and retaining are effective compared to placebo in improving symptoms of abdominal pain, discomfort, and bloating. Just go to the secretagogues. Mainly, they work through the cyclic GMP receptor and pathway, and it's unclear how exactly they improve abdominal pain. It's thought that they do target the afferent nerves, and I think newer evidence is showing that there are these neuropods. Well, what are neuropods? Neuropods are not epithelial cells, but they're these endoendocrine cells, and they form these connections to afferent nerves on the basolateral surface, the other side of the lumen, and then they drive more connection and more afferent signaling or visceral hypersensitivity to the brain, and then more descending dysregulation of the gut-brain axis. So these cyclic GMP compounds can then act on those nerves and improve pain. So that's what the thought is. It's yet to be completely proven and flushed out. Whereas the retaining-agogues with tenapanor, there's physiologic animal studies that have shown that they work on these TRPV1 receptors on the dorsal root ganglion, dorsal root nerves. So we have evidence of how they work on visceral hypersensitivity and improve pain. So we have pretty good evidence that these aren't just medicines that improve bowel habits, but also abdominal pain symptoms and some mechanistic insight into how they work. So I think that that is very, very promising to patients, and that's how I usually explain it to patients, is that we can improve their symptoms with these medicines that work on specific pathways.
Yeah, it's interesting. I think what we're trying to do is we're trying to head towards more of a precision medicine type of thing, target the underlying cause as opposed to the symptoms. And we're working on that. And like you mentioned, with the retaining-agogues like tenapanor, one of the things we know is that it can actually seal tight junctions. And so, a lot of our colleagues, our naturopaths, talk about leaky gut syndrome, which I like to call a more microbiota immune dissociation or dysregulation, leading to visceral hypersensitivity and alterations in motility. But knowing those mechanisms and being able to target those may be more effective. Now, the question always becomes for us, and I think this is the struggle for the three of us, we're going to ask both of you. At the end of the day, you've got these 4 FDA-approved therapeutics, right? Lubiprostone, linaclotide, plecanatide, tenapanor. How do you choose?
So for me, I like having dosages, different dosages. So I like going to the agents like lubiprostone, linaclotide. That gives me a little bit of play in terms of where to start. As a medicine-trained physician, always liking start on the lower dose and moving up. But then there are patients that don't respond to certain medicines, and then being able to pivot relatively quickly is important to me.
So how about you? I mean, you're on the primary care side. What's your thought in this process when they're seeing you in clinic?
I would agree with that. I also have to say it will come down to availability and accessibility of these medications. There are still many areas in the country we know that these drugs are going to require prior authorization. There's also, depending on the payer, they may require prior authorization from a gastroenterologist, meaning that a primary care provider can't prescribe them. So I've actually experienced a variety. Is that also the case where you both are?
Yeah, I mean, I always say the pragmatic portion of me has little thoughts on subtle differences between these medications, but the reality of the situation is it comes down to the 2 big C's, right? Cost and coverage. They're going to tell us what we're doing and where to shift from there. And it's the nice thing is for the vast majority of those therapeutics, they're extremely safe. We're not talking about safety so much with these therapeutics, but overall, not much systemic penetration, no real drug-drug interactions. So for somebody that's other associated comorbidities, the nice thing about these medications, from my standpoint, is they can be used with little fear that they're going to cause any problems. And again, they've all been validated to improve that totality of IBS symptoms, which is very, very important.
And I would argue what you just said, I think, is also important for primary care audiences, because respectfully, and I felt this way about a lot of different drug classes, that I would not feel comfortable prescribing across a lot of different organ systems. But the safety element for primary care providers, I think, could be important.
I think it's very important. I think part of the reason that sometimes IBS is minimized, and it shouldn't be based on what we talked about earlier in this discussion, the burden of illness, is because people have always thought of it as more of a nuisance and that sort of thing. And we know it isn't. So when we talk about things like inflammatory bowel disease, we weigh the risk benefit of the drug to the risks and complications. And I think in the IBD world, the risks of the therapeutics are much higher than anything we have in the IBS world. So there's nothing to fear here when we use these medications.
Yeah, and I think the diarrhea is sometimes overstated when you just look at the data. A lot of the diarrhea is very mild that I've experienced in my patients. So it's not a something that I would fear exclusively. So I think diarrhea shouldn't be something that steers us away from these effective medicines.
And it's something I tell my patients regularly to expect from anything that we're going to be using to treat constipation, and that a tolerance in many cases builds up within the first, 5 to 10 days. So to be aware of that. I think if we set the standard and the expectations, then we don't get this drop off, because we've all seen these patients who walk in regularly who've had drug failures. And of course, our next question is, how long did you take it for? And the answer is 1 to 2 doses. And either it didn't work or they developed diarrhea and they were done. So I think setting expectations for the drug and the way the patients are going to respond is key to this process as well. Now, of course, we've all seen these patients too who walk in the door and say, I want to feel better from my IBS symptoms, but I'm never going to take a pharmaceutical. So what else have you got? So let's talk a little bit about food for a couple of minutes. Fact or fiction? Are low FODMAP diets more effective than, say, traditional dietary advice?
Well, I would say that this is fiction, but I think head-to-head data still needs to come out a little bit more and be flushed a little bit more. Your traditional diets, like the Mediterranean diet, which I think is a very good, healthy diet, can be very effective for patients' symptoms with IBS. The low FODMAP diet is very in vogue. Our data is very extensive about this, but even though it's extensive, it's really a short-term intervention. It's really almost a trial in itself. The first 2 weeks as a trial to see if it's going to be efficacious, and then a nutrition-driven reintroduction of some of these components of the low FODMAP diet to find out exactly what the triggers are in the diet. Now, because there's so much literature on the low FODMAP diet, I think we're seeing the consequences a little bit of a lot of people trying this diet without a nutritionist by their side. And we're seeing a lot of patients be afraid of eating many foods, and they're having these avoidant restrictant behaviors to their diet and being almost afraid of eating many foods. So I think now there's a push to look and find some way to identify the patients that are going to respond to this diet, maybe be by testing, by other historical clues that can then say who's really going to benefit from a low FODMAP diet before just carte blanche introducing it to everybody.
Yeah, I think your point's well taken. I mean, there's even recent data comparing from the University of Michigan the low FODMAP diet to the Mediterranean diet. And while this was a very small number of individuals, they showed that both diets improved symptoms, especially abdominal symptoms. Numerically, the low FODMAP diet worked a little bit better than the Mediterranean, but it wasn't statistically significant. So I think the jury's still out. And, we've also talked about what the Europeans do, right? The MNICE guidelines, the National Institutes of Care and Excellence in the UK, they say, slow down. Chew your food a little bit more, maybe a little less caffeine, a little less alcohol. And they've shown that diet can work just as well, and the quality of life might even be better for it. So I think what it tells all of us is that there's, different strokes for different folks on this process.
A little bit of a nicer diet, right, Darren?
That's exactly. A little bit nicer diet. It's the one I'd want to do for myself, for sure. I'm not a restrictor. So, John, we have about 5 minutes left. I want to ask you how you're integrating brain-gut behavioral therapies into your practice. So, fact or fiction, brain-gut behavioral therapies can be beneficial. And if you think they're beneficial, which ones do you use? Is it CBT? Is it gut-directed hypnosis? And then also, fact or fiction, you have to have a one-on-one with a therapist, or can you actually use digital apps to get people better? Joel, maybe I'll throw this one at you to start.
Wow. I'm going to go back to where we started relative to the stress issue, right? So I think in primary care, we're going to have to figure out if stress causes the symptoms or the symptoms cause the stress. what else is interplaying. We'll do the depression inventory, we'll do the anxiety inventory. But once that has been elucidated and you're going to zero in on how you're going to offer this as a therapy, a lot of our patients are really keen on cognitive behavioral therapy. Now, I will fully admit I'm blessed being at University of Michigan. We have a lot of resources. We have people who specialize in gastropsychology and a lot of very savvy dietitians and a lot of very savvy therapists. I know this is growing. I know not everybody has these resources, but not only can patients benefit from that, there are a number of apps and GI wellness systems in place where patients can do this on their own time and on their own pace and learn about what it is that fits for their own model.
How about you guys down in Georgia using these?
So we are not blessed with a GI psychologist at our institution. And I think GI psychologists provide a very targeted CBT that can be very effective for patients. But again, at maybe Northwestern, at a Michigan, that is available, but not necessarily in Georgia. I know that the 2 US apps that had launched for CBT for gut-directed their treatment have kind of gone off market, so they're no longer available. It just goes to show that even though the therapy may be effective, the way that apps are developed, that's a whole different ball game. I mean, you need to drive user experience and all those kinds of metrics that we don't look at as healthcare providers, neither do our psychologists. So that becomes a little bit of a difficult strategy. I still believe in, CBT at some level. If stress is a driver of their symptoms, I do refer them to a general psychologist who is specialized in CBT, and I do find that beneficial. So even I don't have a GI psychologist, having some CBT expert, which is more available throughout the country, is helpful. So I use them in the patients, especially the ones that have stress-driven symptoms.
And I live in an ivory tower. I'm fortunate to have 6 brain gut behavioral therapists who are amazing, who work on everything. I know we're talking about IBS today, and that's probably where most of the evidence and data is, but everything from reflux to fecal incontinence. So certainly moving forward in the future, I think the only caveat I'd add to this is, to your point, Amal, the CBT ones are either leaving the market or are off. So the apps that are available are gut-directed hypnosis.
Right.
It should be known that gut-directed hypnosis should be avoided if you're using the apps, and anybody that has a history of trauma or PTSD, because that has the potential to reactivate those. So I think we can see there's a lot of different things out there that we now have for treating our patients with irritable bowel syndrome, with constipation. I think the exciting time for all of us who specialize in it, because we can pick and choose, we can mix and match. No 2 individuals are the same. And I think that's what makes treating IBS-C in 2024 very, very exciting. So with that, I'm going to say to my colleagues and friends, thank you very much for your time. I want to thank the audience for their time and participation. And I hope that you were able to get some clinical pearls and we were able to dispel some of the major myths and misconceptions for you today. So thank you very much.
Thank you both.